Now, can
Yeah, right.
Dr. Jordan?
No, it was, and the first case went beautifully. It went great, and I really think that the technology is fantastic. So I look forward to doing more of them.
Dr. Jordan, I'm John Fernandez. I oversee the blog for Baptist Health, and I'm going to write the blog, the story about this, the technology. Can I ask you a couple of quick questions regarding the patient that you said the procedure from Jacksonville? Can you explain a little bit the type of injury she had? I know it was a very tragic car accident, but her husband was killed, I believe, is the write-up that I got, and she had a very traumatic, I guess, injury. Can you speak a little bit about her injury and the procedure itself? What type of injury did she have?
Right. So she had a femur fracture, basically in the mid shaft of her femur, a broken femur, and she underwent surgery to fix it, but she ended up with what we commonly refer to as a non-union, which is basically when the bone doesn't heal, which is not uncommon for these types of very high-energy car accident type of injuries. She had several other procedures prior to this in an attempt to get it to heal, but unfortunately, those procedures weren't successful in getting the bone to heal. She continued, the non-union was persistent, and then so a technique that we that was popularized by a particular French orthopedic surgeon, his name is Mascalet, for these sorts of problems is one whereby we will stabilize the fracture. She had a rod inside of her femur, an intramedullary rod, and so we will create an environment that is more favorable for healing by resecting a block of bone of that area of the fracture until we basically get to healthy bone and healthy, untraumatized bone, and insert a spacer, an antibiotic block of cement, a block of antibiotic eluting cement. And basically what it does is, the Mascalet technique is the eponym, but it's called the induced membrane technique. It actually induces a membrane surrounding that antibiotic block where you've kind of substituted that defect in the bone with this block of cement, and it creates a membrane which histological studies have shown is chock full of growth factors and proteins that help with bone growth. So we let that sit there for about 6 weeks, and then we come back and we do a bone grafting procedure. We basically take out that block of cement and then fill the void with bone graft, taking care to very carefully kind of open the membrane and not destroy it, kind of just open it by dissecting it very gently and then taking the block of cement out and then putting bone graft, and we actually repair the membrane, and it has a very nice healing potential and often is very successful. Now, part of the problems with it are that when you start getting pretty big, the bigger the amount of bone graft you put in, the lower chance of healing for several reasons. One of them is that the body, likes to resorb stuff that it doesn't know what it's doing there. And bone graft is basically just either dead bone or it's material that could be synthetic or biological. But either way, it's not really alive in the same way that the surrounding tissues are alive that have an active circulation and active cells. So a lot of times, when they do fail, the bone graft just gets resorbed by the body, or there'll be certain portions of it, so it'll partially heal but not other parts. And so one of the things that is thought to greatly increase the rate at which bone grafting procedures heal is to have a scaffolding, essentially, which is what this graft cage is. I know of graft cages or similar types of devices with the same sort of philosophy behind them, having been done for years in the spine, for example, for spinal fusions, like vertebral body fusions. But just like Roger was saying, those are made out of metal. Those are implants that stay in that could potentially down the line cause any other kind of secondary effects or sequela. So this is novel and is also nice because it is not only is it 3D printed to the patient's specifications, like we're actually taking the defect and making a reverse 3D model that fits inside that defect, but it's also a scaffolding that be there for the time it needs to be there, and then it goes away. It just gets reabsorbed by the body. Once the bone graft incorporates And part of it is the body resorption biologically, but also the fact that if you just put a massive amount of bone graft in a big defect, a lot of times there's not a structural support, even just by simple gravity. Things tend to accumulate more distal in the defect than proximal, and so it's just there's nothing to really hold it in the place where you want to hold it without using a graft cage. So this is I actually think this is kind of that missing link to the puzzle for these sorts of procedures, where it's good. It was a great idea. The induced membrane technique was changed the way that we treat these injuries, but there was always just like a piece missing, and I think this is that piece. It's the fact that you need some structure, and you need essentially, like I said, a scaffolding to fill, not rebar, but like a scaffolding with which to be able to hold that bone graft both, and it's also, and it helps it to heal. The material itself, if I'm not mistaken, is HA coated as well, and that's also osteoinductive, which also provides a biological support, not just a physical support. And so I really do think it's kind of one of those things that's the wave of the future. I don't think we're going to be bone grafting stuff without it pretty soon, and it just needs to catch on.
That's incredible. You said it's the missing link to the puzzle. Did it replace anything? Was there ever a cage, a previous cage that doctors used in similar situations, in similar cases, or is this a completely new idea of the scaffolding?
No, so like I was saying with the spine cages,
okay.
there's other types of cages that have been around, but not quite like this.
Okay.
They were basically sort of. Yeah, it was this kind of chunk of metal that sits there in order to keep the heights of the vertebrae, the relationship from one vertebrae to another at the correct length.
Right.
And then you pack the inside with bone graft. But the implant itself was, number one, made out of metal, so it was always there and it would never reabsorb. And number two, unless there's something I'm not aware of because I haven't done any spine surgery lately. They're not osteoinductive as well. There's nothing on them that helps the bone to heal and to incorporate biologically into the body. And so this is and the other thing is that you weren't taking into account the other improvement also is the 3D the CT technology and the 3D printing, because like I said, it's in the spine there's kind of there's a little bit of variation, but there's generally sort of set relationships from one vertebrae to the next, how far apart they need to be, where they need to be on top of each other, that sort of thing. Whereas a traumatic defect could be any size, any shape. It could be shaped completely different from the next one because trauma is not controlled, right? So the bone breaks in one way that it doesn't break in another patient, and there's never a 1 or 2 or 3 sizes fit all. So this allows us to look at the shape of the defect, the size of the defect, everything about the defect, and be able to create something specific for that patient. And that technology of using advanced imaging in order to 3D print something for the operating room is also not new, but it's never been used that I'm aware of in this sort of capacity. When I do total joints, I actually use I also use TrueMatch, but I use it for total knees, where they'll use the CT scan and they'll make for me the instrumentation that fits exactly to that particular patient, so that I can make the resections in the bone necessary to be able to fit the implants on correctly. So it takes sort of, I won't say the guesswork, but it takes the intraoperative measurement work out of having to do that in the operating room, which is less precise and less perfect than having a CT scan, which is down to the, each slice is a fraction of a millimeter. So, okay. So it makes things much more precise as well.
And is this technology specific to traumatic leg injuries or bone injuries? But is it to a specific type of injury, right? It's very traumatic.
Like body part. Is it going to be more used in a certain body part?
Yeah.
Yeah, so our products indicated for segmental defects. So it's like basically large bone defects.
And is there a range?
For the technology, obviously could be used for their variety, but this particular product is for that large bone defect.
Large bone.
So what you notice will happen is there's 2 answers to that question. There's the answer that DePuy Synthes will tell you, because that's based on the way that their product was approved by the FDA, which right. means what the indication is specifically as to why the government says we're allowed to use it in this country. And then there's the answer that people like us will give you, which is where we think the clinical applications are, in not just in what the company says that they were approved for, but also what we think it could be useful for, that we're allowed to do,
Right.
which is something that's called off-label uses. Which what I'll tell you now is. I wouldn't even say it's common. I'll say it's probably more the rule than the exception. I think that 90% of what we do day to day is probably technically off-label, especially in trauma with regards to, the process by which the FDA approves stuff is very, very specific, but the variation in what actually happens in clinical practice is very different. And so what I'll say is that this technology and this particular type of implant was made with segmental defects in mind. And what that means is literally a gap, taking a long bone and cutting a gap out of it. And this is used to be able to fill those defects specifically. And, but what I'll tell you is I think that over time, and not even over time, like as far as our capacity to do stuff off label, I think that this can be used really to fill any defect. This can be used probably in a lot of other parts of the body besides large bones and long bones. There will be a time, I'm sure, where we're using this to fill like a defect in a fibular non-union as well, and that's not technically considered a large bone. So there's this application, I think, can be used all over the body because of the CT technology and the fact that it's personalized to that particular lesion, that particular injury. So technically, I think we can do it anywhere in the body, even though right now the company's answer, or maybe whatever they publish on their website, has to say just what they were approved for.
Okay.
Yep.
How is she doing? How is the patient? It's been a month since the surgery, right? Or the graft
Yeah.
cage? Oh. Since
Yeah, so far so good. I mean, she's doing well. The as far as whether or not it's working is a little early to tell. So there's some of this stuff that I think we're going to be able to really do the rah cheering sort of thing once she's already completely healed, probably. But I do think that it's newsworthy and especially dissemination worthy to our community, because I think they deserve the top of the line and most sort of advanced care. To say that, number one, I think the technology is fantastic, and number two, she's doing very well. So right now she is back home in Jacksonville. She saw the doctor that referred her to me for routine, post-operative follow-up, and he's been keeping me abreast of how she's doing. I'm actually due to call her this afternoon after clinic. Actually, I think I have a call with her around 4:30 this afternoon just to see how she's doing. She had her stitches taken out, and she's using crutches, even though she's walking on it, just to help her balance out a little bit.
and the implant was July 16th. I said the surgery was July 16th. Was the implant of the true match cage?
That was the second surgery, the one where we used this implant. There was a surgery 6 weeks earlier,
Right, okay.
8 weeks earlier, where we did the initial, the first part of the procedure, where we resected the bone, created, the defect, and then put the antibiotic spacer in.
Okay. Is there any?
And I think I may have just lost you. I'm not sure.
No. And I say the size of this graft cage. I know that probably it could be arranged depending on the injury or the area. I mean, can you give me in this case, was it how big the cage was in effect, essentially, that you used, or centimeters wise, or is there any?
I think it was about 8 centimeters, if I'm not mistaken. I believe I could look it up, and I'm sure that I have the information written down on my operative reports. But I think it was somewhere around 8.5 centimeters long. Now, the exact dimensions of the graft cage itself, we can also get, I'm sure,
That'd be great, yeah.
as far as how wide and and the radius of it, because it was kind of cylindrical. It's a cylindrical shape.
Okay. And this is the first and only time you've used the true match graft cage, correct? On this patient, this is the only time.
Yeah. So far, that's it. And I don't even know if any other surgeon has done another one yet because of the whole COVID stuff. I think I may still be the only one that's used it. I'm not sure if another surgeon has implanted one.
In the world.
You're definitely the first one. I think up to date, I probably correct me, we'll have 4 cases procedure done already. So
yeah.
And one more, doctor.
It's funny because one of my partners, actually, John, Dr. Barelli.
Yep.
You guys may want to.
He's got one in early September.
He was well, and I think I beat him out.
Yeah.
Another one coming up. So really, it may turn out that the first 2 surgeons in the world to use them are both in the same group, are both partners.
Now, doctor, you mentioned she had several surgeries before where they're trying to, and there was no union, and I mean, how do we know how many surgeries and since how many months going back? And did she I don't know when the accident was exactly, but
I'll have to look in my records or ask her again and talk to her. I don't know exactly off the top of my head, but I know for sure she had the one after the injury, and she had at least one more, if not two more. So she either had 2 or 3 surgeries before seeing me.
and these were using bone grafts, correct, to try and
Yeah. So my
reset?
understanding, if I go back and look, is that she had one what's called an exchange nailing, which means that so sometimes when you put a rod or a nail into a femur, so sometimes they don't heal is because there isn't enough the implant allowed too much motion at the fracture site. So they'll do what's called an exchange nail, which means that we'll actually take that nail out and put in a thicker one, basically, because the stiffness of the rod increases actually, by a factor of 3. I think it's three times the radius of curvature, or whatever it is, if I remember the science correctly. But basically, the thicker the rod, the more stability there is, or the stiffer that it gets. And so I think they did an exchange nail once in order to increase the stability, and then the next one, the next time I believe was a bone grafting one.
Okay.
So I think they which are all both accepted and very common sort of non-union procedures. We usually try to do those types of things before doing something like what I did, which is actually cutting out a segment of the bone, because we had decided in our workup that bone was just basically dead. The tips of where the fracture was, the fracture ends had very little to no healing potential anymore.
Wow. And injuries of this type, I mean, I don't know how often you get this type of traumatic bone injuries. I mean, how common are they? I mean, or hopefully they're not very common, but I mean,
so long bone fractures are some of the most common fractures in the body. Long bones being, the humerus, which is up in your arm, the femur, which is in your thigh, the tibia, which is your shin bone. Those are the most common long bone injuries, but they are very, very common especially in high energy trauma. Car accidents, having been hit by a car, bicyclists. In our community, we see it a lot in car accidents. We see it a lot with marine injuries. So like people boating, a lot of boating injuries and a lot of long bone injuries from boats. And so the problem with long bones is, as far as healing is concerned, is that the shafts of long bones don't have quite as robust of a circulation as the ends of bones, where we call the metaphysis, which is kind of the part where if you imagine a femur, it kind of is, there's a shaft and then it kind of flares as you get to the end, right? It kind of widens a little bit and then you get to the tip of the bone, which is called the epiphysis. So that area, that flare is called the metaphysis, and there's a ton of blood supply that goes through that area. Whereas as you get further up the shaft, the type of bone that you have there, which is called cortical bone, is not quite as vascular of a bone, and the coverings around it, called the periosteum, are a little bit thinner, and there's not quite as many vessels and capillaries that go in there. And so not only is, when you break a long bone, it tends to higher energy injury. It takes more force to break the shaft of a femur than it does a lot of other bones. So it's already a more forceful injury. There's been more energy imparted. Internally, when your bone breaks, the soft tissues kind of strip off of the bone as it's breaking, and so there goes like whatever that circulation that's there, which is already less than in other parts of the body. So long bone non-unions tend to be, if I'm not mistaken, I don't remember the statistics off the top of my head, but they're the most common places where you get non-unions to begin with, where the bones don't heal. Right. So the most common non-unions are long bone non-unions.
Okay.
But how many, I guess maybe, how many of these large defects do you get? How often do you get these large defects? Just maybe that's more, that applies to big situation.
So I'll give you two answers. One is how many I see personally, which is probably somewhere in the neighborhood of 5 to somewhere between 5 and 10 a year. So maybe less than 1 a month. But I will tell you that there are, some centers that their entire practice is dedicated to it. There's some centers, to name a few, there's one big one up in New York. There's one in Baltimore. There's one here in Palm Beach that are deformity centers, that there are orthopedic practices that are dedicated purely to deformity correction, limb lengthening, and also these types of problems, which are segmental defect, non-union repairs, and stuff like that. So they're out there. They're out there, and I think that as our practice grows, because there's not really a whole lot of representation for that in a rapidly growing community. I mean, Miami is just getting bigger and bigger. My personally 10 a year, and maybe my partner's 5 or 6 a year will turn to more. Okay. So they're out there. I mean, I don't do a ton of them, but I've done a lot in my training, and I've done a fair amount in practice, and now we could capture a lot more of them.
Yeah.
Great.
I'm just curious, was this patient originally, when the first injury, was it the same hospital you were at, or was they referred to you? Was this patient referred to you, or is it just part of the hospital?
This particular patient was referred to me by a physician that I had worked with in a prior life, who I know well, who's an orthopedic doctor in Jacksonville. I have a couple of patients actually, so I'm currently, as we speak, actively taking care of 4 other patients that have had segmental defects that I've taken care of. And they were all, so the most recent surgery besides hers that I did for this was, I believe, February. So the last one that I had done, a masculé and bone grafting procedure, was in February. I had one in January, one in November, I believe, and then this lady who I did now in July. So yeah, every few months we get one, at least every few months. And if Graft Cage had been around for those, I most definitely would have put them into those as well.
Okay.
So that's why I'm pretty sure moving forward we're going to be using it.
Fantastic.
Oh,
Fantastic. Well, if I think of anything else to ask you, Doctor, I'll email you. But I think anyone else here have questions for the doctor? Or?
I actually do. I wanted to just understand, because I think, so John is really going to speak to the kind of more non-clinical audience for our blog. And then maybe David, who's on the media relations side, we can pitch to maybe some more of the kind of trade publications, more clinical route. So I think what would be helpful, Tobin and Roger, if you guys had, any publications that you have relationships with, or ideas of where we can feature this kind of information, if you can share that, that would be great. Another thing that I think would be interesting for my knowledge, I know that it's about a 10-day turnaround for the 3D implant. And I just wanted to understand too, like kind of the pathway. So let's say, patient X, gets in a car accident and needs to go to the emergency room. Dr. Jordan, then you do a procedure there to stabilize and do kind of imaging to understand. And is that where you get the imaging for the 3D implant when they go through the emergency room, or is that scheduled at a later time? Like, I guess what I'm trying to understand is there always an operation before having to do the 3D implant?
So typically this is going to happen in the realm of post-traumatic reconstruction, which is the way I see the majority of the application for this. It's going to be down the line once a patient has already had the injury, has already had initial procedures. Those procedures resulted in the patient's bone not healing, and now we're in what's the phase called, post-traumatic reconstruction. So you ended up with a non-union, and now you're here to see me to fix it. So for the most part, that's really where the application is going to be for this. I do see over time, and I don't know how much time, but over time as this becomes more and more mainstay, where there are, I'm sure, going to be surgeons that are going to start trying to use it in a more acute setting. So I could see down the line the indications or the applications of this technology and this implant to expand towards acute injuries, where we would potentially maybe in a very bad trauma setting, patient has a very large open segmental defect, and for those sorts of patients, what we'll do is we'll put them in what's called an external fixator. We'll put them in a frame that it sits outside the leg, but has pins that goes in the bones of the bone to
like
hold
the
the relationships together,
thing.
the length, the alignment, the rotation. Yeah, so that's one of them. So I could see patients being put into that and then brought back to the office once the soft tissues have healed, once the defect, the soft tissue problems have gotten better, using it in an acute setting in order to reconstruct the bone, 10, 14, 21 days after the initial injury. So as an initial treatment, as what we would call definitive treatment. So the X-fix and the washout and all that would be temporizing, and then we would do a definitive treatment. That's also a perfectly acceptable application for that. And I'm sure that, there's other, the Synthes people, I'm sure, can tell you with the Synthes experience over the decades that there's a lot of stuff that maybe was initially used in an application that was for not so acute conditions, and then over time surgeons have found more acute applications for it. And I think that's probably where the journey will be that this takes.
Yep.
And
Yeah.
I'll just jump in really quick. So Dr. Jordan, so we're like Katie mentioned, we're probably going to go the trade publication route for now. With this story, the patient, there's usually a patient component to these stories, and I think you added another very good reason why maybe we should hold off on the patient part, because we're still kind of waiting on the outcome a little bit. Seems like there's a little more road to recovery to go on that. And on top of that, we want to be sensitive to the fact that there's a difference between having a positive medical outcome and a positive personal outcome. This was a tragedy for her, losing her husband. So we want to be sensitive to that. And we don't want to be too celebratory when, even though there's a good medical outcome, we have to be sensitive to that. So that kind of rules out, which I think is good. This is a good fit for maybe that traditional mainstream media, local network affiliates, but great publication. So the more we talked and the more I heard, it definitely sounds like that's the way to go with that. So Dr. Jordan, there probably would want to interview you at some point.
Yep.
So, it's something to keep in mind. We'll of course keep you posted should that happen. And then on
yeah, that's fine with me.
Okay, great.
I think that so my sort of impetus for putting everybody together, Baptist and DePuy Synthes, was because I think I see three different opportunities, right? I see the opportunity, which is mutually beneficial on both sides, to disseminate to the community that this technology is